Aloha, everyone, and welcome to the University of Hawaii Cancer Center's Quest Starlight Lecture Series. Thank you all very much for being here. My name is Brenda Hernandez. I'm a researcher here at the UH Cancer Center, and I'll be your moderator for the webinar today. Today's session will focus on breast cancer with presentations by two of my colleagues. Just some housekeeping details before we start. This webinar will be recorded, and the recording will be available along with the presentation slides at the Cancer Center website following this presentation. And you can also find at the website the recordings and slides from our previous Quest Starlight lectures in case you missed those. We invite you to submit questions during the presentation using the Q&A box found at the bottom of your screen. And we will address your questions following the presentations. And also during the Q&A session, at the end, there will be a survey link displayed in the chat box, and we ask that you please provide your feedback to us using that link. And a thank you gift will be mailed to those who do complete the survey. So let's get started. Our first speaker today is Dr. Lenora Liu. Dr. Liu is an associate professor and researcher at the UH Cancer Center. She received her PhD in genetics from the University of Hawaii. And she went on for postgraduate training at the Fred Hutchinson Cancer Center in Seattle, Washington. Since returning to Hawaii, Dr. Liu has focused her research towards understanding the underlying biological factors that contribute to differences in cancer risk and survival among the diverse racial and ethnic populations here in our state. Dr. Liu?
Thank you, Dr. Hernandez. Thank you, everyone, for joining us for this Starlight Lecture Series. And it's a great pleasure for me to give you some background about our research here in the UH Cancer Center on breast cancer. I'm going to share my screen and go through some of our research highlights. Okay, sorry. Let me just, let me just get to the presentation mode. Okay. So today my talk is essentially going to introduce you to some of the research that's ongoing at the UH Cancer Center. And I want to kind of take a bird's eye view of the breast cancer in Hawaii from population down to the biological research efforts that are ongoing here. Just some background about breast cancer. So breast cancer is a result of changes or mutations in the genome, the DNA, that can cause normal breast cells to become cancer cells. Breast cancers start from different tissue in the breast, but the most common form of breast cancer originates from the epithelial cells that line the ducts. And the normal function of these epithelial cells is essentially to differentiate. And when a woman is pregnant, these cells differentiate and produce milk and basically function to send milk into the lumen and out through the nipple. Now, for breast cancer patients, sorry, okay, sorry. So for breast cancers, these epithelial cells that become invasive essentially enter the lymph system and spread through the body. So there are several breast cancer risk factors, and a breast cancer risk factor is anything that contributes to an individual's risk of developing breast cancer. There are risk factors that you can change and others that you cannot. And a couple of examples of risk factors that are modifiable, these are risk factors that can be changed, these are risk factors like being overweight or obese, being physically active, your dietary habits, drinking alcohol or smoking can also affect breast cancer risk, having children, parity, as well as breastfeeding can also impact breast cancer risk. use of oral contraceptives and hormone replacement therapy can also impact risk. There are also risk factors that are non-modifiable, and these, a few examples are gender, aging, as well as genetics. So for the breast cancer rates in the US, this is offered by the CDC. This is basically a heat map of new breast cancer cases in the US in a 5-year period between 2014 and 2018. And this is Hawaii here on the bottom. And we have the 5th highest incidence rate in the US. So you can see in this heat map, the state of Hawaii is colored dark blue to indicate that we have a relatively high breast cancer incidence rate in the nation. And this is a heat map of the rate of breast cancer deaths in the US by state in the same 5-year period. And for Hawaii, we have actually the lowest mortality rate in the US when compared to the other states. So we have a very high incidence, but we have low mortality. And when you are considering breast cancer in comparison to other types of cancers in Hawaii for female cancers, breast cancer is the most common cancer diagnosed in women in Hawaii. You can see in this pie chart a good proportion of the cancers, in female cancers in Hawaii are breast cancer, with the second being lung and bronchial cancer, and third, colon and rectum. And second to lung cancer, breast cancer is one of the top causes of cancer death for women in Hawaii. You can see here the pie chart. Lung and bronchial cancer is a little larger than breast cancer. So for the most part, it's the second most common causes of cancer death for women in Hawaii. So breast cancer is found more commonly in women older than 55 years old. And this is basically a bar chart indicating the age distribution of breast cancer cases. And you can see here, the majority of breast cancer cases are diagnosed at, in women above 55 years old. So much of our effort is really trying to understand breast cancer in our very unique multi-ethnic population. And one important aspect of this study is to understand if the rates of incidence and mortality are different across the different multi-ethnic groups. And what we see is there are differences in breast cancer incidence rates by race ethnicity. So if we are looking at the different racial ethnic groups here on the x-axis and the age-adjusted rates per 100,000, we see that the racial ethnic group with the highest incidence rate in Hawaii are Native Hawaiians. And the second highest are Japanese, followed by whites. We see that Filipinos and Chinese as an Asian subgroup have lower incidence rates than Japanese. And this is a chart that demonstrates the invasive breast cancer incidence trends over a 30-year period. And what we see for the most part is that this is the incidence trends for Native Hawaiians. We can see that for the most part, their incidence has remained higher than the other racial ethnic groups for decades. And we are really trying to understand how to reduce this and reduce this disparity in breast cancer incidence. You can see in blue, these are whites, and in yellow, the yellow line represents Japanese. So interestingly, we see increase in more recent years of incidence for Japanese women with breast cancer. And we also see racial ethnic differences in breast cancer mortality rates. This is the, again, bar chart showing the different racial ethnic groups and age-adjusted rates. And we see that Native Hawaiians have the highest mortality rates when compared to the other racial ethnic groups of Hawaii. And interestingly, as I mentioned, Japanese have high incidence rates in previous slides, but their mortality rates are relatively low. The second highest are found in white women. And these trends over multiple decades are consistent with what we're seeing currently, where Native Hawaiians have consistently had higher mortality rates than the other racial ethnic groups. And in blue, we have here whites, and yellow, Japanese. So their rates remain lower, relatively lower. So we also see racial ethnic differences in breast cancer stage at diagnoses in Hawaii. And just to give you a little background, this is obtained from the SEER site. So when we're talking about stage, and we are essentially referring to the extent of cancer spread in the body. And so when we're referring to localized stage, this is essentially the tumor is confined to the primary site. Regional stage represents the spread to the regional lymph nodes, and distant stage represents cancer that has metastasized. As you can see from this pie chart, the majority of breast cancers that are diagnosed in the localized stage. And the 5-year survival rate, the 5-year relative survival, it differs based on the stage of diagnosis. You can see patients diagnosed with a localized breast cancer have very high 5-year relative survival of 99%. And patients diagnosed with the regional stage have also a very high 5-year relative survival of almost 86%. For patients diagnosed with the distant stage, their survival, 5-year relative survival is markedly reduced down to 29%. And the stage information can also be informative about just overall an individual's relative survival. These are just compilations of survival trends. So when we look at the stage at diagnosis by race ethnicity, and we see that for the Native Hawaiians, they have relatively high rates of advanced stage at diagnoses relative to Japanese and whites. What we do see, interestingly, for Japanese is they have relatively high rates of localized stage at diagnoses. So these differences in stage at diagnoses may also suggest to us the differences in maybe contributing to the racial ethnic differences that we're observing in mortality. And as I mentioned, when we look at incidence-based mortality by stage and race ethnicity, you can see when we're just looking at patients with localized stage breast cancer, when they're diagnosed with localized stage breast cancer, we do see racial ethnic differences in mortality, where we are observing Native Hawaiian women diagnosed with localized stage breast cancer do have higher rates of mortality when compared to whites or Japanese patients diagnosed also with localized stage breast cancer. And when we're looking at the mortality rates for advanced stage breast cancer across the different racial ethnic groups, again, we do see that Native Hawaiian breast cancer patients have a higher mortality rate when compared to Japanese and white women also diagnosed with advanced stage breast cancer. And we also see differences in breast cancer subtype at diagnosis in Hawaii. So just to give you a little background, when we're referring to breast cancer subtype, we are essentially referring to the combination of expression for estrogen receptor, progesterone receptor, and human epithelial growth factor receptor, HER2 expression. And this is just a immunohistochemistry of the different subtypes where you're seeing the brown staining. This would be cells, breast cancer cells that are expressing one or two of the three markers, or in fact, all three markers for the luminal B subtype. So this particular breast cancer is expressing estrogen receptor, progesterone receptor, but is negative for HER2. This is another subtype where it's positive for all three markers. And here we see a breast tumor subtype, which is HER2 positive, but negative for estrogen receptor and progesterone receptor. And here, this last subtype, we refer to as triple negative because this subtype has no expression of either of the three markers. And what we do see is that there are differences in survival curves, essentially, for the different subtypes. And here, this is a bit of a complicated slide, but I would like you just to focus on the solid lines. HR represents expression of both estrogen receptor and progesterone receptor. So the blue line represents the breast cancer subtype, which is expressing both hormone receptors, but is negative for HER2s. And this subtype essentially is associated with the best survival. We go to the red curve, which is a subtype which is expressing estrogen receptor, progesterone receptor, and HER2. You see the survival curve is slightly lower, and the green line represents tumors that are not expressing hormone receptors, but are expressing the HER2 protein, the HER2 receptor, and their survival curve is a little lower. And this is the triple negative subtype. And this particular subtype is associated with essentially the poorest breast cancer specific survival. So essentially this slide is to show you that there are differences in breast cancer specific survival based on the subtype and the expression of hormone receptors or HER2. And what we see is that there are differences in breast cancer subtype distribution by race, ethnicity. And again, interestingly, what we are seeing is that Native Hawaiians have actually a high percentage of breast cancer subtypes that are expressing the hormone receptor, which is very interesting because this is a subtype generally associated with good survival. We also see for Japanese in Hawaii that they have a high percentage of expression, of the breast cancer subtype, which is expressing the hormone receptors. And this is just another survival curve here where we're looking at survival across the different racial ethnic groups by hormone receptor positivity. And we see that for when we're comparing breast cancer survival, 5-year relative survival across the different racial ethnic groups for the Native Hawaiians, that are expressing hormone receptor positive, that have hormone receptor positive breast cancer, that they have the poorest relative survival when compared to whites or Japanese, for example. And when we look at hormone receptor negative breast tumor subtypes, we see also that Native Hawaiian women with hormone receptor negative breast tumors have poorer survival relative to whites and Japanese. So those are the trends that we are observing across our multi-ethnic population. And much of our cancer research at the Cancer Center is focused on understanding the factors that influence these differences in both breast cancer risk and survival in Hawaii. So our ultimate goal is to better understand these trends and the factors that contribute to these disparities, so that we can decrease risk and improve breast cancer survival in our multi-ethnic, multicultural community. And I just wanted to kind of share with you, I won't go into the details, but I wanted to share with you the complexity of the factors that contribute to both risk and survival. There are host factors, there are host environment factors, treatment factors, and lifestyle factors that impact both risk and survival. And these are, some of the examples of the host factors like age, race, ethnicity, genetics, epigenetics, inflammatory response, metabolic state, and as well as the microbiome. There are also environment factors like the built environment and access to healthcare, environmental pollutants, and treatment factors such as treatment based on tumor biology, stage at diagnoses, treatment based on NCCN guidelines, as well as lifestyle factors, diet, obesity, comorbidity, physical activity, alcohol consumption, as I mentioned, smoking, and as well as the psychosocial state. And what I hope to illustrate with this slide is that these factors all are interacting and contributing to one's risk as well as survival. And so when we approach these factors as researchers, we are thinking about the complexity of these factors and generating essentially teams with different expertise to address these risk factors as well as survival factors. And we have different specialties like epidemiologists. We have the psychosocial aspects, prevention, control. We also have the basic scientists like myself who are basically trying to understand the biological mechanisms that are underlying these disparities in both risk and survival. And we all interact, and we interact with the clinicians, as Dr. Fukui will talk about some of the trials, as well as consult with the community and patient advocates to get some guidance and insights into the research approach about addressing some of these critical multi-ethnic, multicultural aspects of cancer research. So, we do have a women's breast cancer, essentially a women's cancer focus group that encompasses individuals of multiple disciplines, so that we meet once a month so that we can discuss how to address some of our research questions in a team manner. It really does take a village to do this type of research. And I thank you for your attention, and look forward to questions when we have our panel discussion. Thank you.
Thank you, Dr. Liu, for the great presentation. Our next speaker is Dr. Jamie Fukui. Dr. Fukui is an associate professor and researcher at the UH Cancer Center. She completed her residency and hematology and medical oncology fellowship at Mount Sinai Hospital in New York City. Dr. Fukui is a breast medical oncologist, and her interests are in breast cancer clinical and translational research, developing clinical trial protocols, and providing cancer care to residents of Hawaii. Dr. Fukui?
Great, thank you so much for that wonderful introduction, and thank you, Dr. Lenora Liu, as well, for a wonderful overview and presentation. I'm going to be talking about some breast cancer studies, and before I go into some of those studies that are unique to our patients here in Hawaii, I wanted to go over just some review of clinical trials. Right now, we actually have a community advisory board that is ongoing at the same time, where we review protocols that are new and that are undergoing a feasibility assessment to see if this is the right type of trial for our patients here in Hawaii. And so we know that clinical trials are important, not only because worldwide cancer cases, unfortunately, are going up. They're projected to increase by 50%, leading to almost 21 million cases in 2030, but also the number of people dying from cancer as well is going to go up almost 60% to about 13 million in that same time frame. So it's very important that research continues to improve overall our standard of care, and we do that by doing research. And so the treatments that we have today used to be clinical trials about 5 to 10 years ago. And so participating in clinical trials today may become the new standard in the future. So there are a lot of different kinds of clinical trials. Probably the most commonly known are the treatment trials or the new medications or drugs. But there are a bunch of other types of clinical trials that can be helpful, prevention trials. And I'll go into one that we're looking at right now on island, as well as a screening trial. There are supportive trials, which actually help to support people, whether they're undergoing cancer treatment or the side effects or long-term outcomes from those treatments. There are more correlative laboratory science type trials looking at biomarkers or special blood tests that we can do to improve how we treat patients. Healthcare delivery as well, and we have several clinical trials ongoing right now looking at how we can provide best care to patients. There are diagnostic trials looking at different kinds of ways to diagnose cancer, and then quality of life trials. So these are more focused on making sure that people continue to live a very high quality of life, even with cancer or after their cancer treatment for survivorship. So as you may know, and you might have heard of, there are different phases to clinical trials. We actually have a very rigorous process that goes from the basic laboratory, where scientists do some preclinical assessment and testing in cell lines and then in animal models. And then it finally goes to phase 1. And this is what we call first in human studies. And we are currently looking to grow our phase 1 unit here at University of Hawaii Cancer Center. So stay tuned the next little while for more information about that. The purpose of a phase 1 clinical trial is really to see, is this drug safe? It's a first in human testing, and based on pre-laboratory and preclinical data, it looks like it's effective, but we have to make sure it's safe first. And so it's usually a small group of people that participate in these trials, and it's usually patients who have already exhausted a lot of other treatment options. And so that's anywhere to 15 to 30 people, and it usually takes a few months. After we figure out if the drug is safe and we kind of have an idea of what types of side effects people might be having, we go on to phase 2 trial to see, is it effective? Does it really help with cancer? And what are some of the dosages that might be most appropriate? And so this uses, about less than 100 people, and it can take a little bit longer, sometimes up to years. And at this point, this is where the FDA may approve a drug. So we can utilize this earlier before maybe it's become standard of care. Then it goes on, if it graduates and it is safe, it's effective, and we know what some of the side effects are, it goes to phase 3. And phase 3 is when we're comparing between what is our standard that we do for anybody off a trial and compares it to that. And that's where we really see which one is now the new standard. And that usually takes a lot more people and participants, up to thousands, and can take several years to decades. And then at that point, we figure out which is the new standard. Phase 4 is ongoing, so that's looking at long-term effects. So we never stop learning about these medications and how they can affect people long-term. So this is a very simple schematic of how do clinical trials work. We usually have a specific study population. So let's say, for instance, breast cancer patients who have early stage breast cancer. They get randomized to 2 different groups. One is going to get standard treatment alone. The other one is going to get standard treatment and something additional. And that's usually either a new drug or it could be a new biomarker testing. And then after that, we assess the response and we compare the responses. And so if you notice, regardless of what group that person is randomized to, there is still a standard treatment that's given. So nobody is just getting a placebo. They're always getting the standard, but they may get something above that, which is the whole point of doing the clinical trial. There are some benefits, like I mentioned before in the phase 2 setting. Sometimes people can get access to new or novel treatments. And we did have a clinical trial that was open here that was phase 2, and people participated on that. And now that drug is part of our standard of care. Patients on that trial got it about a year earlier than those that now get it as standard of care. So that's just one example where we can provide new medications for people earlier and part of a treatment trial. All of these clinical trials, we learn from them. So even if a drug doesn't necessarily graduate to the next step, we learn about that. We learn, and it contributes to our cancer research. In general, and I hear this a lot, is it safe to be undergoing a clinical trial? And it is. It goes through a high quality of care, a mandatory quality assurance that's nationally recognized, it's standardized, and it gets scrutinized scientifically by a group, and it gets reviewed. So if something new comes along, we're always looking at those protocols. Is this the most up to date? Is this the most current? If it's not, then we go ahead and shut down the study and we find out what is our new standard. But if it's something that we still have questions about, it's open. So it's an increased oversight to someone's care. There's a whole research team that's involved. So in addition to the treating physician and other clinicians, there is a principal investigator who leads the clinical trial. There's a clinical trial nurse who helps to perform some of the assessments or also sees the patient on the trial. There are clinical research associates, and we have a whole group at the University of Hawaii Cancer Center in the clinical trials office. And right now they're meeting at that community advocacy board. And they are well known to the protocol and they know some of the more details about that, as well as the data specialist or analysis. So there's a whole added layer or research team that goes into a clinical trial. Despite all this information that I'm sharing with you today, unfortunately, clinical trial awareness is not that great still. And so about 85% of clinical trials actually fail to get enough patients on the trial. So we might go through all the testing in the lab, all the testing, and then we get to the point where we need to accrue to clinical trials, but not all the clinical trials will accrue enough patients. About 80% of them also fail to finish on time. So often we will keep a trial open to make sure that we have enough patients that are participating, so we have enough information to actually determine whether or not that certain intervention is beneficial or not. About 50% of all the studies only accrue 1 to maybe even no participants. And so that's a lot of work that goes into opening up a study, but sometimes it's only 1 or not even a single participant. In fact, the pharmaceutical budget, about 40% of its budget goes into recruitment. So that's a very important aspect to clinical trials. And then unfortunately, about 30% of patients, for whatever reason, drop out of a clinical trial too. So there are all these potential barriers that make it a little bit challenging for clinical trials. I want to share a little bit about the statistics about clinical trials nationally. Children participate, about 70 to 75% of children with cancer are actually on a clinical trial. It's actually considered the standard of care for a child to go on a clinical trial. It is part of their algorithm for treatment. If there's no clinical trial available, then they will get whatever the latest standard of care was. And that's probably partially in part because a lot of the thought behind cancer treatment for younger kids is we need to come up with things that are going to cure these kids. And there's a lot of participation with that. And I think that probably is in part why kids do so well with cancer, among other things. Unfortunately, only about 3% of adults with cancer are on a clinical trial, which seems incredibly low considering that our standard treatments were based on clinical trials that were performed 5-10 years ago. So we're basing about 3% of the cancer population to come up with our standard of care. And so we are trying as a one step closer, it's called 20 by 25, to increase the clinical trial accrual to any study by the year 2025 to 20% for adults. And so part of the reason that people might not know about clinical trials or feel a little bit unsure about it, or they're concerned, will this really work? Or concerned about costs. And so there are a lot of different myths out there, but it is something that is ongoing, and that's why I'm presenting this today to review that. As I mentioned, only 3% of adults are on clinical trials, and about 95% of those participants are of Caucasian descent. And so we're getting a very limited type of demographic in our patient and participant population. And so there's a lot of ethnic diversity that's lacking in these trials. And Hawaii is very unique, and there's not a majority as far as population, racial, ethnically. And so it's often underrepresented in our clinical trials. And so, so we often would think, does this reduce the generalizability? Are we able to take that clinical trial that was predominantly done in one type of population? Can we generalize that to our population here in Hawaii? And so that's an ongoing challenge that we have, because that is where we get a lot of our information and research. And so one of the ways that we can address that, of course, is by participating in clinical trials here. And we've done so pretty well with a number of clinical trials, and I want to highlight a few of them here. Before I do that, I want to mention Hawaii incorporates, the University of Hawaii Cancer Center incorporates not just the state of Hawaii, but also the Pacific. And so the Pacific Island populations, unfortunately, have a high incidence of breast cancer as well, and late stage. And as Dr. Lenora Liu mentioned, we already know that the incidence of breast cancer among Native Hawaiian women is quite high, as well as mortality. The same actually goes for the Pacific Islander population as well. In fact, it's the highest group of women that have never had a mammogram. In fact, only 26 of Micronesian women 40 and older ever had one. And so this is a big area we can easily try and help to increase screening for early detection. And so the clinical trial here that I'm going to highlight is called TMIST. It's a national trial that's been open for several years, and we've contributed considerably to this trial. It's a screening trial, so it's looking at 2D versus 3D mammography and seeing if there are differences in the screening rates of cancer detection. And so this is where it is randomized between 2D, which is our standard, or 3D mammography, and they're followed up to 8 years, and followed it at the time that they, if they develop breast cancer. And so if you're interested in learning more about this, there is some information here. Alana Vance is our clinical research associate, and her number is there, and then the email is there that's listed. And so that is currently ongoing. I also wanted to briefly talk about a registry that we are developing right now with Dr. John Shepard, who is a researcher at University of Hawaii Cancer Center, called the HIPPY-MR. It's the Hawaii and Pacific Island Mammography Registry. And there are few registries already nationally through the Breast Cancer Surveillance Consortium. As you can see, several on the West Coast as well. Actually, only a few of them are active currently, San Francisco being one of them. And we hope to learn more about women in our state, what types of mammographies and features of the mammography, so density and other risk factors that we would collect during their screening mammography. Because our population is quite unique, women here tend to have denser breasts. And so one of the reasons why the TMIS trial is important, maybe we're learning that the 3D mammography might be more beneficial in our patients and in our women for screening. And if we were to have a state mammography registry looking at common risk factors and mammographies, screening mammographies, we might be able to develop a strategy for how to tailor screening for our women here in the state, which is not captured in the rest of the US. So this is some of the information that would be collected. So it's a comprehensive data resource where we collect factors, as Dr. Lenora Liu had mentioned, some of the common risk factors that contribute to breast cancer, such as family history, age, as well as body mass index, breast density, as I mentioned before, the screening mammograms and other screening modalities that somebody might have, but then also some of the outcomes data. So this is, did they develop cancer and what type of cancers did they develop? So it's a whole continuum. This would be very important for us to learn more about our women here in the state. So there's a lot of unique strengths about this, which is kind of highlighted in pink too. It's again, from the beginning all the way to if they develop breast cancer. So it's longitudinal of multiple breast imaging. And it's from the community-based radiology facilities that we utilize here in the state. And it's gathering data from our diverse population of women here. And it's capturing outcomes as well. This is, I think, one of another really interesting study that is ongoing that people have really enjoyed, which is an exercise study. Right now, the Rehab Hospital of the Pacific is utilizing a program called iCare, and it's for all cancer survivors. And it's a 12-week program. And we've utilized it for breast cancer. So in partnership with the University of Hawaii Manoa Kinesiology Department, where their students are going through practicum, partnered with one of those students 3 times a week, 90-minute sessions, 12 weeks, and they have a body assessment before and after those sessions. So at baseline and after the 12-week sessions. And that body composition analysis is done by a Dr. John Shepard's lab, and that's looking at changes in body fat, in body composition, so muscle, fat, water, and those things that can be figured out not only with special blood tests, but also with special DEXA scans. And so we've partnered with our community members to offer this to breast cancer survivors up to 2 years after diagnosis. And if they wanted to just participate in the exercise portion of it alone, it's for any cancer survivor. So I put both of those up here. It's an ongoing free program, and it's a way that we can help monitor and improve health, but it might even help to reduce breast cancer recurrence, which is one of the things that we always hope to prevent and help with survivors. So the information there is listed, and I can have this available to everyone as well with my slides, but there's a link or there's a QR code as well as an email or phone number to call if you're interested in either of these studies. So in general, we follow the National Cancer Guidelines, and they're called NCCN guidelines. And so that those guidelines help us to recommend certain prevention or diagnoses or management of cancer. And I want to emphasize, there's in the national guidelines, they say they believe that the management of any patient with cancer should be on a clinical trial, and that participation is strongly encouraged. And so that's what we hope to do and provide the best care for our patients here in Hawaii. So the take-home messages, if it wasn't obvious, is that the best treatment option for cancer patients are on a clinical trial. There are many kinds, from treatment trials, which are probably the most commonly heard about, but they could be supportive trials, quality of life trials, screening trials. And participants on a clinical trial receive the highest level of care. They're getting an added layer of a research team along with their clinician and treating physician as well. Most cancer patients who are adults don't participate in clinical trials, but we know some of the barriers, and so education is one of them. So learning more about clinical trials is part of figuring out how we can spread the word about that. And we know that clinical trial benefits participants, society, and science. And so with that, I'll leave some of the resources for our Cancer Center Clinical Trials Office here, the number, as well as some information nationally about what's available in the US as far as clinical trials.
Thank you for the wonderful presentation, Dr. Fukui. So now we're going to open up the session to some questions that have come in. So if you have not had a chance to post your questions, you can put them in the Q&A box seen at the bottom of your screen. So let's go to the first question. Someone is asking, was there a chart on age and mortality? And probably Dr. Liu, you'd be the best person to answer that question.
Okay, yeah, I did not actually include a chart on age and mortality, but for the most part, the rates that I did give were age adjusted. If the question is essentially the differences in mortality by age, we do see that the age group with the highest percentage of mortality is the 65 to 74. This is again, not just for the state, but in the nation. This age group with 65 to 74 years is their mortality percentage is 24%. This would be the highest, the most common age group with the highest mortality.
Thank you, Dr. Liu.
Okay.
So this question is about clinical trials. Are the 3% adult patients in breast cancer only, or is it generalizable to other cancers? And Dr. Fukui, could you answer that?
Yes, sure. Sorry, that wasn't clear. That's for all cancers, not just breast cancer. Actually, breast cancer clinical trials, I don't know if it's broken down, but I tend to be a little bit biased. I think that women do quite well at participating in clinical trials, but that's overall with all cancers. So that's 3%.
So Dr. Fukui, I have a follow-up. Are our participation rates in Hawaii similar to the rest of the US?
It is, unfortunately. It might be a little bit higher during certain years, but it is pretty similar to national. We are looking at ways that we can improve that. As well, we do have such a varied, rich background of different races and ethnicities, and so often language can be a barrier as well. And so that is something that we're trying to address going forward. And of course, trying to provide the most culturally appropriate types of trials for our patients here.
Thank you. So this next question, I think Dr. Liu, describe what you know about the Native Hawaiian women's lifestyle, maybe in reference to breast cancer risk.
I see. Okay. So much of what we know regarding the differences in breast cancer risk as well as survival is generated through this large epidemiologic cohort that is called the multi-ethnic cohort. This includes both white, Native Hawaiian, and Japanese women from the University of Hawaii, from Hawaii, as well as African American and Latino women from California. So what we have learned from many studies and reports in the multi-ethnic cohort is some dietary differences, as well as BMI differences. We do see higher rates of overweight and obesity in Native Hawaiian women, which increases their risk of breast cancer. And we also, interestingly, from this multi-ethnic cohort study are also seeing, as we are seeing with the state registry, is a high rate of estrogen receptor positive breast tumors. And this is associated with postmenopausal women. So the risk factors for estrogen receptor positive or hormone receptor positive breast cancer in postmenopausal women increases with increasing BMI or increasing obesity. So that may also be one aspect of lifestyle or modifiable risk factor that may be influencing risk for Native Hawaiians women. I hope that that kind of addresses some of this question.
Thank you, Dr. Liu. So Dr. Fukui, this question is, how closely do clinical trial researchers work with OBGYNs?
Yes, so like I mentioned, there are some screening trials that are ongoing, and OBGYNs are the ones who typically, if it's not their primary care doctor, it will be the OBGYN who will order the screening mammography or screening breast imaging. And so we do make every effort to let not only primary care doctors know, but also OBGYN colleagues. So, and there's certain clinical trials too that they might be able to have a hand on the pulse for. So they might be able to see more, for instance, high-risk patients. So if somebody has a family history, they might be seeing their OBGYN and who might order some genetic testing. And so they're already kind of thinking in that way. And so they often do refer to like a high-risk breast center, for instance, for closer follow-up. So it goes both ways.
Thank you. Okay, so this question is also about clinical trials. And how much is invested in doctor education and training about clinical trials? I had to ask my oncologist for a clinical trial because he had not suggested one to me. I was in a placebo group along with the standard of care.
Mm-hmm. So now it's part of standard hematology oncology training. Clinical trials are part of any academic center because it's, again, part of the national guidelines that patients receive the best care, which is on a clinical trial. So it'd be very rare for somebody to be board certified in hematology oncology and not have had that experience. That being said, some practices are different. Some people that remain in academics, they often will continue to accrue to clinical trials, but it often can be challenging in other settings where research might not be as supported. In some smaller practices, for instances, or that don't have connection to a research facility. We don't have a university hospital here, but we have the Hawaii Cancer Consortium. So we work with our community partners to accrue to clinical trials, and through the University of Hawaii Cancer Center's Clinical Trials Office.
Thank you. So I believe this question is in reference to clinical trials participation as well. How do off-island patients figure into these options?
That's a really great question, because as we know, with all the challenges with telehealth now, it actually has helped to iron out some of those challenges we had before with clinical trials. So there are certain trials that we can offer remotely, as well as follow-ups, or work closely with a partnered local oncologist on the neighbor islands. But it is an ongoing challenge because with any clinical trial, there is that research team that has to have that safety oversight. And so if there's something available on the neighbor island, then we can open a clinical trial there. Often they don't have some of the support sometimes to have some clinical trials that might be more labor intensive open. But we do often have people fly out if they are eligible for a clinical trial, and that is part of the clinical trial coverage oftentimes. So it is something that's available to anyone in the state if they're able to be assessed at a place that has the research team. So we do have many people from the neighbor islands that participate as well.
Thank you. This next question, I think for Dr. Liu, how does body mass index or BMI factor in with the ethnic groups?
Right, so this is a great question. So we do know that, excuse me, that for Asian women, their BMI is generally lower. And yet we're seeing a higher incidence in, for example, Japanese women in Hawaii. And so there's some ongoing research again in the multi-ethnic cohort that's showing that it may be not just BMI that may be a good important indicator, but rather adiposity, like where adiposity is deposited in the body. Is it visceral adiposity? Is it in the essentially sort of the apple versus pear body shape? And, you know, the deposition of fat cells essentially, and the cytokines that they express may be influencing breast cancer risk across maybe differentially influencing breast cancer risk across the different racial ethnic groups.
Thank you. So this next question is, any thoughts as to why Native Hawaiian women have a higher breast cancer mortality rate? Dr. Liu?
Okay. I may need some help here with Dr. Fukui's also clinical knowledge. This is a really important question, one that we're really struggling to understand with our research. I don't have any specific answer for that. Maybe perhaps Dr. Fukui
Dr.
has some.
Fukui, do you have some thoughts on that?
Yeah, I think that, like Lenora said, it's very complex, where there are all these factors that can contribute to outcomes. So even with the subtype that's supposedly a good type of hormone dependent breast cancer, where we expect good outcomes, there might be other factors that influence that outcome to be more poor. And so taking into account social determinants of health, which is basically looking at where somebody lives, works, plays, their environment has a large role. And so that is now being looked at more in depth in certain clinical trials and certain clinical studies. So I think it's probably going to be multifactorial at the end of the day.
Including biology, which is what we are working very hard on, is understanding if there are biological differences that contribute to differences in mortality. This is a very important question.
So this is a related question for Dr. Liu. For your slide that shows survival by hormone receptor status, why do you think Filipinos have a huge drop in survival for hormone receptor negative tumors?
You know, that's actually very astute and a good question. We noticed that also, and without sort of having done the research, I don't have a specific answer. It could be, again, treatment. It could be biology. There could be so many factors that contribute to that. Do you have any thoughts on that, Dr. Fukui?
No, although we have looked, and it's anecdotally, but we have started to see more younger patients present with breast cancer, kind of younger than the average age, which was mentioned, older than 55. We're seeing younger patients. I don't know if that's reflected statewide. It might be anecdotal in the practice that I'm seeing that, but that tends to be a more aggressive type of biology. And so we did see with the preliminary analysis looking at Filipino women that perhaps they were being diagnosed at a younger age, but I think we don't have large enough studies to really say that, but it probably does have something to do, again, with multiple things that influence that.
Okay, thank you. So this next question, what is the phone number for NCI Cancer Center's clinical trials? This person only got to write down the UH Cancer phone number. So
Okay.
may I ask if we could write that into the chat box so that everybody could have that? And
Sure,
then we'll
sure.
also make that available to, again, the slides and the recordings will be available to everybody at the at our website following the presentation. So the next question, are clinical trials available to Neighbor Island cancer patients? Kauai doesn't have a permanent oncologist. Dr. Fukui?
Yeah, that's a great question again. And this is an ongoing challenge with not only Neighbor Islands, but other parts of the US as well. Having a oncologist that is there for longer term. And so there are some potential clinical trials that are available utilizing more remote access. So this would be things that Dr. Erin Bantam is looking at for survivors, looking at mindfulness meditation for neuropathy, or mindfulness meditation for anxiety in cancer survivors. And so those are two ones that could be done remotely. And as far as treatment trials are concerned, that is an ongoing challenge, just because there has to be that special research team and oncologists that would participate in the clinical trial. So we're hoping to help support our colleagues out there by, if there is someone who needs to be seen or could be referred for a clinical trial, we will often see them remotely. And if they are eligible, they will come to Oahu for clinical trial.
Thank you. Okay, so this is also about clinical trials. Regarding the mammography screening clinical trial, if someone is already receiving 3D mammograms, can they join and continue to receive 3D?
So because it is a randomized, unfortunately, you can decide to be on the study as long as you are okay with being randomized to 2D versus 3D. But if you have further questions, just to go over some of those details, we can give you some information about that with our clinical research associate.
Thank you. And also for Dr. Fukui, could you tell us more about preventative trials?
Right. So there are several preventative trials that are ongoing in other types of cancers, I believe. They're looking at, I think there's a liver trial that is recently going to open, maybe seeing how BMI and how it can contribute to fat deposits in the liver. And if, altering that with lifestyle changes might decrease someone's risk of developing liver cancer, since that is a type of cancer that unfortunately is more prevalent in our population. As far as breast cancer prevention trials, there are some nationally that were looking at certain vitamins, certain diets. There are ones that are looking at also preventing recurrence of breast cancer using similar lifestyle changes. And so right now, I would have to look back to see if there's something available at the moment, but I don't believe anything right now for prevention of obtaining breast cancer or of getting breast cancer. But in general, several lifestyle modifications are recommended. So that's getting some 30 minutes of exercise a day, plenty of fruits and vegetables in your diet, and managing stress.
Thank you. But Dr. Liu, do you have breast cancer survival charts by molecular subtype for different stages?
I don't. Dr. Hernandez, do you know if we've done that for Hawaii? I'm trying to recall if we have it by subtype.
Right. Some of the subtypes that we have from the Hawaii Tumor Registry are, so we're not, we may or may not be able to have enough numbers to be able to calculate specific survival. But in general, we can do that. We just don't have the data here today. But that data is available. And if you would like specific information about it, you can contact the Hawaii Tumor Registry and we can help you generate that data.
Thank you.
The next question, there's a study that's going to be started to examine methods for reducing ectopic fat. And that information for anyone who is interested is on the Cancer Center website. Thank you, Dr. Boucher, for mentioning that. The next question, I guess this is addressed to either of you, Dr. Liu or Fukui. Could it be that genetic mutations like PALB2 in Asian women that predisposes them to breast cancer? This person has a friend who is a Chinese Korean who has a breast cancer that's PALB2, and this person also has that. And they're at high risk of breast cancer? Could either of you address that question?
So genetics in general don't contribute as a majority of risk, as a risk factor for breast cancer. Only about 5 to 10% of breast cancers are linked to a genetic mutation. So that's even with BRCA1 or 2. So majority, at least in 2021, we might find out more genes contribute to breast cancer, but for now it's only about 5 to 10%. So majority of breast cancers aren't linked to a genetic inherited abnormality at this time that we know of.
Are there any studies or clinical trials looking at epigenetics? Dr. Liu or Dr. Fukui?
Epigenetics in terms of methylation.
So there are some clinical trials looking at drugs which target epigenetics, because there's certain drugs that will demethylate or methylate DNA, which is kind of how DNA unwinds or stays tight during the cell growth. So we utilize some of those drugs in clinical trials, but that's more for treatment trials. But if you're referring to studies looking at epigenetics for risk, I'm not aware of any at the moment.
And are there
Yeah.
any clinical trials for advanced stage breast cancer?
Yes, there are, and every month or so they're updated. Right now, of course, the meeting is going on to look at new protocols. We have almost one in every single disease group that's a subtype of breast cancer. So there are some for advanced stage breast cancer that are available on Island, yes. And if you are interested in kind of doing a quick search, you could go to clinicaltrials.gov is the national search, but also through the University of Hawaii Cancer Center website, you can go to clinical trials office, and then there's a way to search through a search engine there to see what's available here on Island.
And I believe this might be the final question regarding clinical trials. Is airfare covered for off-island participants? And what about health insurance coverage and accommodations?
Yes, so airfare is covered for neighbor island participants. And often that will be through the insurance provider, but also through the clinical trial itself sometimes. If either of those are not available, then we often will go to grants or foundation funds where people have donated so that people who are not here on Island can get access to clinical trials. And so there are several different ways that we can try and accommodate patients from neighbor islands.
Sorry, there is one final question. Is BRCA still used as a guideline?
So the BRCA is, I think what it is asking, I hope I'm answering this, is does that change our guidelines for screening? And it does, and it does change how we would advise somebody who had a BRCA mutation. So if somebody does have a BRCA1 or 2 mutation, the genetic counselor would go over what are the increased risk of certain cancers and what type of screening should that person have. For breast cancer, that may mean an MRI. It may mean considering removing both breasts. It may mean, alternating between an MRI and a mammogram every 6 months for screening. So there are a few things depending on what was seen with and who developed the BRCA mutation. So.
Thank you. Okay, thank you, Dr. Fukui and Dr. Liu, for your wonderful presentations. And I hope that everyone, was able to, gain some knowledge today and get their questions answered. And we just want to extend our appreciation for all of you for participating in our webinar. And as a reminder, before we leave, please complete the survey to help us plan for future Quest events. And the survey that is available in the chat box, but also a survey link will be emailed to each participant at the email address that we have for you. So at this point, I just want to say thank you again and mahalo and have a good evening.
Thank you.
Bye.
Thank you.
Bye.